Hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Delcina Bean Burrows, and this is lecture number 14. In our lecture today, we will be specifically looking at the digestive system. In our lecture today, we will cover the learning objectives, the key terms, functions of the digestive system, the gastrointestinal tract, accessory digestive organs, metabolism and nutrients, diet and health, and aging and the digestive system. So before we get started, eating with friends is a social activity that seems to improve digestion. Why do you think a big meal is easier to eat in a group than alone? Have you ever felt full, yet still found room for dessert? Why do you think this is possible? Now, in terms of our learning objectives for today, upon completion of this chapter, you will be able to discuss the importance of the digestive system as it relates to the practice of manual therapy, list the functions of the digestive system, list the 4 layers of the gastrointestinal tract or the GI tract, and describe their functional characteristics, name and locate the major organs of the GI tract and describe their functions, name and locate the accessory organs of the digestive system and describe their general functions, compare and contrast the basic metabolic processes of anabolism and catabolism in regard to macronutrients, and discuss digestive system changes that commonly occur as the body ages. And here are the key terms that we will consider: digestion, the enteric nervous system or ENS, ingestion, mastication, metabolic rate, motility, mucosa, muscularis, peristalsis, peritoneum, segmentation, serosa, and submucosa. We begin our discussion of the digestive system by considering how amazing the system actually is. It indeed is a convoluted pathway of chambers and tubes called the gastrointestinal tract, plus several accessory digestive organs. This amazing system processes nutrients in food and makes them available to the body for immediate use, storage, or elimination. Like the skin, the GI tract serves as both a barrier and an interface between the external and internal environments, filtering out unwanted substances and absorbing essential nutrients. The digestive system is populated with millions of neurons that sense and regulate its functions and produces numerous peptides that can stimulate responses in the brain and spleen. Perhaps this is why the gut seems to have its own wisdom or gut instinct and intelligence based on peptide communication between the nervous and digestive system. This instinct can create a physical awareness of emotions such as fear, anxiety, or excitement before there is conscious recognition by the brain. In terms of the functions of the digestive system, it serves to break down food to be used or eliminated by the body. The enteric nervous system, or the ENS, gathers sensory information from the GI tract. The ENS directs the release of enzymes and frequency of GI smooth muscle contraction, and information is also shared with the brain, where gut sensations, emotions, thoughts, and memories are developed. Our illustration here shows the enteric nervous system. This is the brain of the gut, and it can function independently from the central nervous system as well as in response to autonomic nervous system regulation. There are 6 functions of the digestive system: ingestion, secretion, digestion, motility, absorption, and elimination. Time now for our first What Do You Think segment, and remember, the What Do You Think segments are designed to develop your clinical reasoning skills. Why do you think people tend to eat more during the winter months than the summer months? And what everyday analogy would you use to demonstrate each process of the digestive system? Now let's discuss the gastrointestinal tract, or the GI tract. The digestive organs involved in transporting and processing food make up the gastrointestinal, or GI tract. The GI tract begins at the mouth and continues through the pharynx, the esophagus, the stomach, the small intestine, or SI, the large intestine, and ends up with the anus, where waste products are excreted from the body. Each organ carries out specialized digestive or absorption processes to provide nutrients necessary for cellular metabolism. In terms of the layers of the digestive tract, even though a small number of organs make up the GI tract, each has the same 4 layers of tissue forming the wall of the tract. And they are the mucosa. This is the innermost layer, and it is a mucous membrane which secretes, coats foods and particles to help propel them through the tract and protect the wall from irritation and damage from enzymes and acids. The submucosa, this is the areolar connective tissue layer which binds the mucosa to the adjacent muscular layer. There is also the muscularis. This is 2 distinct types of smooth muscle fibers that make up the 3rd layer of the GI tract. And the serosa, this is the outer layer of the digestive tract, and it is the innermost layer of the serous membrane called the peritoneum. And here we see illustrated the 4 layers of the digestive tract. The 4 layers of the GI tract wall include the mucosa, the submucosa, the muscularis, and the serosa. The neuronal plexus of the ENS, or enteric nervous system, are located within the submucosa and the muscularis. And here we see illustrated the peritoneum, the omentum, and the mesentery. The parietal peritoneum lines the abdominal cavity, while the visceral peritoneum surrounds the abdominal organs. Notice that the duodenum and the pancreas lie posterior and outside the peritoneum. Double folds of peritoneum form additional supportive and protective membranes called the mesentery and greater and lesser omentum. Now let's discuss the mouth and the pharynx. Food enters the GI tract through the mouth, where it is chewed. Mastication is the mechanical process of chewing in which pieces of food are smashed or broken into smaller pieces. While the teeth play the primary role, the cheek and lip muscles and the tongue move and position the food so it can be thoroughly chewed. For this reason, the teeth and tongue are considered accessory organs of the digestive system. During chewing, food is mixed with saliva secreted by the salivary glands. Saliva serves as a lubricant to help food pass through the GI tract and begins the process of chemical digestion. It contains the enzyme amylase, which breaks down starches, which is a type of carbohydrate. To demonstrate this process, you can hold a small piece of bread in your mouth and chew for a few minutes. Once food has been chewed, the mixture of food and saliva, now called a bolus, is swallowed. Swallowing or deglutition is an involuntary reflex that moves the bolus through the pharynx and into the esophagus. During swallowing, the soft palate and uvula, which is the small mass of tissue hanging from the soft palate at the back of the mouth, are raised to prevent food from entering the nasopharynx, and the epiglottis is pulled over the opening of the trachea. And here we see illustrated the salivary glands. There are three pairs of salivary glands: the sublingual glands beneath the tongue, the submandibular glands under the mandible, and the parotid glands, which are anterior and inferior to the ear, the superficial to the masseter muscle. Let's take a look at the esophagus. The esophagus is the muscular tube just posterior to the trachea that connects the pharynx to the stomach. It serves as a passageway for food, and no digestion takes place here. Lubricated by mucus secretions, the bolus moves through the esophagus by way of peristalsis, a series of wave-like contractions in the smooth muscle layer which propels food along the GI tract. Although peristalsis begins in the esophagus and continues throughout the GI tract, it is most apparent in the lower half of the stomach and throughout the small intestine. Vomiting is the non-technical term for reverse peristalsis, a protective reflex of the GI tract. If the lining of the stomach becomes irritated, as happens with bacterial food poisoning and viral infections like the flu, receptors in the stomach wall signal the emetic reflex center in the medulla oblongata. The medulla signals smooth muscles in the stomach to contract in a reverse peristalsis sequence, which simultaneously signaling involuntary contractions of the diaphragm and abdominal muscles that forcefully eject the stomach contents. And here we see illustrated peristalsis. This is the coordinated wave-like contractions of both the circular and longitudinal muscle layers that propel food forward along the GI tract. Now let's take a look at the stomach. Food passes through the esophagus and enters the stomach, which is the sac-like muscular organ located in the upper left quadrant of the abdominal cavity. The stomach has three regions: a large proximal portion called the fundus, a central body, and a narrow distal portion called the pylorus. While an empty stomach is smaller than a closed fist, its inner mucosal layer has hundreds of folds called rugae that allow it to expand to accommodate large quantities of food. The thick muscularis layer is strengthened by an additional inner layer of smooth muscle with an oblique fiber arrangement. Smooth muscle rings called sphincters are located at the proximal and distal openings to the stomach. These ring-shaped muscles contract and relax to control the flow of food into and out of the stomach. The esophageal sphincter lies between the esophagus and stomach and is also referred to as the cardiac sphincter. The sphincter that separates the stomach from the small intestine is called the pyloric sphincter. The stomach plays a role in both chemical and mechanical digestion. When food enters the stomach, hydrochloric acid is secreted to begin the breakdown of proteins and destroy pathogens that might enter with the food. Simultaneously, mucus production and increases to protect the stomach lining from the strong acid. The stomach also secretes pepsin, a protein digesting enzyme, initially secreted in an inactive form called pepsinogen to protect the stomach lining, pepsin is activated by the secretion of hydrochloric acid. Strong, smooth muscle contractions churn and mix the stomach contents with these gastric juices to form a semi-liquid substance called chyme. Chyme is forced against the pyloric sphincter by way of peristalsis, stimulating the sphincter to open. Each time it opens, only a small amount of chyme is allowed to push through into the small intestine. When it closes, the remaining chyme is forced back into the body of the stomach, where it is subjected to further mixing. Because the pyloric sphincter regulates the process of gastric emptying, it normally takes about 4 hours for the stomach to empty after a meal. It can take up to 6 hours if the meal is high in fat. And here we see illustrated the stomach. The three regions of the stomach are the fundus, the body, and the pylorus. The muscularis layer has an additional oblique smooth muscle layer that helps produce smooth contractions to thoroughly mix the stomach contents. Now let's discuss the small intestine, or SI. The small intestine is the location of most of the digestion and absorption. It has three portions: the duodenum, or retroperitoneal, the jejunum, and the ileum. The small intestine secretes large amounts of mucus. Also, enzymes from the liver and pancreas enter through the duct in the duodenum, stimulated by secretin and cholecystokinin, which is CCK. And here we see illustrated mechanical digestion from segmentation. The circular layer of the muscularis contracts to create segments that mix the contents of the small intestine. And here we see illustrated the internal anatomy of the small intestine. In illustration A, we see the Pancreas. They are covered with thousands of tiny projections called villi. In illustration B, each villus has a lacteal surrounded by a capillary bed for nutrient absorption. And in illustration C, the villi are covered by epithelial cells with microvilli. Now let's take a look at the large intestine. The large intestine extends from its junction with the ileum to the anus, forming an arch around the small intestine. It begins at the cecum, which is a short pouch-like segment separated from the ileum by the ileocecal valve, and includes the colon, the rectum, and the anal canal. The longest portion of the large intestine is the colon, which has several regions. A vertical region, called the ascending colon, is located on the right side of the abdominal cavity. It connects to the transverse colon, which crosses the upper abdominal cavity just below the stomach and then folds and extends downward on the left side, which is now called the descending colon. The intersection points between the three regions are named according to the closest organ. So the hepatic flexure is the bend between the ascending and transverse colons, while the bend between the transverse and descending segments is called the splenic flexure. At the distal end of the descending colon is a short S-shaped segment called the sigmoid colon, which ends at the rectum. The last few centimeters of the rectum make up the anal canal, which ends at an opening called the anus. And here we see illustrated the regions and flexures of the large intestine. Now let's take a look at the large intestine. The primary location for the large intestine is for the reabsorption of water and compacting of waste. Vitamin K and some vitamin B is produced by bacteria in the colon, and it is also responsible for defecation. Let's now consider the manual therapy applications with respect to the large intestine. Direct soft tissue manipulation to the abdomen is indicated in some digestive system conditions and contraindicated in others. Chronic constipation is one of the most frequently cited indications for abdominal massage. Although supported by anecdotal evidence, its effectiveness is not likely due to mechanical loosening or movement of fecal matter through the colon. Instead, abdominal massage seems to relieve constipation by decreasing stress and sympathetic tone and stimulating parasympathetic activity to enhance motility and peristalsis. Therapists must always determine the probable cause of constipation, since it may be a sign or a more serious metabolic condition or mechanical blockage. With conditions such as irritable bowel syndrome, Crohn's disease, and ulcers, general massage may be prescribed and can be helpful, but abdominal massage may be contraindicated. So we see here a very nice table illustrating the summary of the GI tract functions. And we look first at the organs that are listed. The organs that are listed to the left here are the mouth and the pharynx, the salivary glands, the esophagus, the stomach, the small intestine, and the large intestine. We see by the way the table is structured that the mouth and the pharynx play a role in both ingestion, which is eating, secretion, also mechanical and chemical actions in terms of digestion. They also play a role in motility and absorption. But there is no role that the mouth and pharynx play in terms of elimination. The salivary glands play a role only in secretion. The esophagus plays a role in secretion by way of mucus and in motility by way of peristalsis. The stomach plays a role in terms of secretion, digestion, motility, and absorption, but not in elimination. The small intestine plays a role in secretion, mechanical and chemical digestion, also motility, and also absorption, but it does not play a role in elimination. And the large intestine plays a role in secretion. It also plays a role in motility, absorption, and then finally elimination, which is defecation. Time now for our next What Do You Think segment. What household items could you use to construct a model of the GI tract? In a manual therapy session, what changes or precautions should the therapist take after learning that a client has just consumed a big meal? Now let's take a look at the accessory digestive organs. With the exception of the teeth and the tongue, the accessory digestive organs are glands located outside the GI tract that supply the tract with important chemicals and enzymes that aid in the digestive process. In addition to the salivary glands already discussed, the accessory organs include the liver, the gallbladder, and the pancreas. Now let's take a look at the liver and the gallbladder. In terms of the liver, it is located in the upper right quadrant. It has a large right lobe and a small left lobe. The lobes are divided into lobules made up of hepatocytes. Bile is secreted into bile ducts that move from the liver to the gallbladder. The liver stores fat-soluble vitamins and glycogen, and it converts ammonia to urea. It also filters and detoxifies blood, and it destroys red blood cells and recycles or eliminates the byproducts. In terms of the gallbladder, it is situated just under the right lobe of the liver. The gallbladder delivers bile to the duodenum. And here we see illustrated the liver and the gallbladder. The digestive secretions of the liver, gallbladder, and pancreas pass through ducts that merge and share a common entrance to the duodenum. Now let's consider the manual therapy applications with respect to the liver and gallbladder. It is important for manual therapists to remember that organ dysfunctions are a common source of referred pain. Right shoulder or neck pain may indicate liver or gallbladder dysfunction, and low back pain and hip pain is a common indicator of kidney disorders. If viscera are the source of pain, there are usually associated signs such as nausea, sweating, and pale skin, while direct manipulation in the abdominal area may be contraindicated in some cases. Abdominal massage and visceral manipulation techniques can be important therapeutic interventions when treating many conditions, including indigestion and neck and low back pain. Indirect techniques such as foot reflexology or meridian therapies might be considered as well, since they have been shown to be effective at stimulating digestive organ functions. Now let's discuss the pancreas. The pancreas is 5 to 6 inches long and is situated behind the stomach in the upper left abdominal quadrant between the duodenum and the spleen. Like the duodenum, the pancreas is retroperitoneal. While the pancreas is an important endocrine gland, 99% of its cells are engaged in exocrine functions, making it a vital accessory digestive organ. Enzymes from the pancreas are transported through the pancreatic duct to the duodenum, where they are active in the chemical digestion of proteins, fats, and carbohydrates. These digestive enzymes are mixed and transported in an alkaline fluid called pancreatic juice, which protects the lining of the small intestine by neutralizing the acidic chyme that has just left the stomach. Enzymes in pancreatic juice and their digestive actions include the following: amylase, which is similar to the starch digesting enzyme in saliva. Amylase is a primary component of pancreatic juice. Lipase, this is for proper digestion of fats and depends on its highly active enzyme. Lipase breaks down fat into more absorbable components such as glycerol and fatty acids. Trypsin, this enzyme is a protease, meaning it digests protein into amino acids. And these enzymes, together with small amounts of lactase, maltase, and sucrase, which are the enzymes that break down sugars, and other proteases secreted by the duodenum, are responsible for the majority of chemical digestion that occurs in the GI tract. Time now for our next What Do You Think segment. A client reports nagging right shoulder pain. What questions and/or objective assessments would help you identify the cause of the pain? Why do you think the pancreas and duodenum are located in the retroperitoneal space? Now let's take a look at metabolism and nutrients. You may recall from previous lectures that the term metabolism refers to all the chemical reactions that occur within the body. Metabolism includes anabolic processes in which complex molecules are formed from simpler ones, tissue is created or repaired, and molecules such as hormones, neurotransmitters, and ligands are synthesized. Metabolism also includes catabolic processes such as glycolysis and the Krebs cycle, which break down complex molecules to produce ATP. Both anabolism and catabolism rely on the body's intake and assimilation of nutrients through the digestive system. The nutrients required for health can be divided into two broad categories: macronutrients, which are the carbohydrates, lipids, and proteins needed in large quantities to meet the body's energy demands, and other substances such as vitamins and minerals, and they are categorized as micronutrients because the body only requires small amounts to maintain homeostasis and health. And of course, the other essential nutrient, if you will, is water. The next nutrient we will take a look at is lipids or fats. Lipids or fats are provided from our diet or from adipose and can be converted into ATP. Triglycerides are broken down into dietary fats that are then further broken down to glycerol or fatty acids. Fats are the body's second choice for energy. Fat stores are used for insulation, cushioning of vital organs, hormone production, construction of cellular organelles, and stored energy. Excessive fat consumption leads to fat accumulation. The next nutrient we will take a look at are proteins. Proteins are large molecules that are formed from amino acids. They are absorbed into the bloodstream by way of the small intestine. Some examples of proteins are actin, myosin, keratin, collagen, elastin, enzymes, receptors, and hundreds of peptide molecules. Let's take a closer look at the role of vitamins and minerals. Vitamins are needed for growth and normal metabolism. We have the fat-soluble vitamins, which are vitamin A, D, E, and K, and we have the water-soluble vitamins, which are vitamin B and vitamin C. In terms of minerals, minerals are needed for homeostatic mechanisms like pH, fluid, and energy balance. And the minerals that we are referring to are calcium, phosphorus, potassium, sodium, iron, magnesium, and others. Now let's take a closer look at water. Water is the primary component of all body fluids. Water is responsible for transporting substances and chemicals around the body. And water also functions to facilitate motility and the action of enzymes in chemical digestion. So let's take a look at nutrient usage according to our table here, table 14.2. The table is broken down in terms of the actual nutrients, beginning with carbohydrates. Then we have lipids, we also have proteins, vitamins, minerals, and water. Carbohydrates are digested and absorbed as glucose. Physiologically, they are catabolized for energy via glycolysis and the Krebs cycle. And they are also converted into glycogen to be stored in skeletal muscle and the liver for future use. When it comes to lipids, they are digested and absorbed as triglycerides. They are broken down into glycerol and fatty acids that can be catabolized for energy. They are also stored as adipose tissue, necessary for absorption and storage for fat-soluble vitamins, hormone production, maintenance of plasma membranes, and cushioning and insulation of the body and vital organs. Next, we have proteins. Proteins are digested and absorbed as amino acids. They are catabolized by way of inaccess and can be stripped of their amino group by the liver and catabolized to produce ATP, but are the body's last choice for energy production after carbohydrates and fats. In terms of how they are anabolized, they are used for all types of protein synthesis, and they are necessary to make and repair tissues to form enzymes, also receptors, antibodies, hormones, and ligands. In terms of vitamins, vitamins support normal metabolic function by serving as coenzymes in chemical reactions. Minerals support the homeostatic mechanisms, including pH fluid and energy balance. They are also important components of the blood, bone, and tissues. And many minerals serve as coenzymes that help regulate chemical reactions within the body. And then we have water. Water is necessary for cellular health and maintaining homeostasis. Primary component of all body fluids is water, and so they are essential for the transportation of enzymes, hormones, and chemicals throughout the body, and they facilitate the action of enzymes that create chemical digestion, digestive motility, and absorption. Now let's consider the manual therapy applications with respect to the consumption of water. For decades, manual therapists have been reminding clients to increase their water intake after a session in order to flush out toxins that therapy has released into the tissues. But there is some debate as to whether or not there is any real scientific evidence to support this concept. Water must be processed and absorbed in the blood and lymph through the small and large intestines just like any other nutrient. Our understanding of metabolism should lead us to question the belief that catabolic processes create toxins that get stuck in muscle, fascia, and skin. The idea that external manipulation could then release these substances into the bloodstream is also highly suspect. Suggesting an increase in water intake to clients may still be helpful, but for different reasons. An increase in water intake will assist the rehydration and lubrication of tissues, especially fascia. They also support nutrient absorption and facilitate the elimination of waste products. Let's take a look at diet and health. We know that our food choices are influenced by a broad spectrum of factors. Clearly, our bodies have nutritional requirements, but what and how much we ingest can be affected by our emotional state, our daily habits, socioeconomic influences, cultural norms, memories, and beliefs. Physiologically, eating is regulated by homeostatic mechanisms that balance energy consumption with energy expenditure. Hunger, the sensation of discomfort or weakness that signifies the body's need for food, is regulated by centers in the hypothalamus that respond to changing levels of nutrients in the blood. When nutrients levels drop, the hypothalamus causes us to feel hungry, and when nutrient levels rise, we feel full or satisfied. Since catabolism produces most of the body's heat, our stimulus to eat is also closely related to the mechanisms that control body temperature. Metabolic rate is the measure of the amount of heat produced by the body. While the body's metabolic rate shifts throughout the day in response to food consumption, physical activity, sympathetic responses, or hormones, each person has a baseline energy requirement called the basal metabolic rate, or BMI. BMR, sorry. The BMR, represented in calories of heat, is the amount of energy a body needs to support basic life functions such as breathing, heart rate, and kidney function. Individuals' BMR differs to factors such as lean body mass, stress levels, thyroxine production, age, gender, and even climate. This explains why people tend to eat more during cold weather and less when temperatures are warmer. In addition to the homeostatic mechanisms that mediate hunger, eating is affected by a powerful reward-driven response. Our senses, particularly taste, are linked to pleasure centers in the brain, so when we eat something with a taste that appeals to us, we are driven to continue eating it in pursuit of the associated pleasure sensation. Some people recognize and control this desire or appetite, understanding that they do not need the food, they simply want the food. But in others, this pursuit of pleasurable sensation becomes an addiction, driving them to eat more and more, even when they are physically full. This reward response can override the body's homeostatic mechanisms and make us feel hungry even when we are completely full. This equation is further influenced by the availability of foods and our memories, social environment, attitudes, and mood. As in all issues related to health, we must consider eating holistically. Our diet and food choices ideally work together to feed the mind, emotions, and spirit, as well as to meet the nutritional needs of the body. With respect to the manual therapy applications regarding diet and health, we know that as allied health care practitioners, most manual therapists are aware that dietary change can serve as an important therapeutic tool. For example, some therapists know that the type of dietary fats an individual consumes can have a positive or negative influence on inflammatory conditions such as arthritis or lupus. Other therapists may have experienced health benefits from increasing intake of vitamin D or taking certain herbal supplements. Recognize, however, that giving nutritional or dietary advice is outside the scope of practice for manual therapists unless they also have training and licensing as a registered dietitian or nutritional therapist. Every individual body is unique and has a unique chemical environment, and there are often large variations in people's responses to identical dietary therapies. Clients may misinterpret a casual conversation on supplements or food choices as professional advice, so it is important that you neither avoid these topics altogether. If they are discussed, make it clear that you are not providing professional advice in this area. And time now for our final What Do You Think segment. Why does the body choose to catabolize carbohydrates first, then fats, then proteins for energy consumption? Describe the difference between hunger and appetite. Which do you think is a bigger challenge for people in your community? Now let's discuss aging and the digestive system. Age-related changes in the digestive system include decreased secretion, motility, and tone of the muscularis layer of the GI tract. Changes in the ENS include decreased feedback on enzyme and hormone release, as well as an overall decrease in internal sensations. For these reasons, many elderly people experience greater digestive discomfort, such as increased belching and flatulence. Some common conditions associated with increased age include periodontal disease, difficulty swallowing, gastritis, gallbladder problems, constipation, diverticulosis, and hemorrhoids. For our first Pathology Alert segment, let's take a look at heartburn or acid reflux. When acidic gastric juices back up in the lower end of the esophagus and cause irritation, it can produce a painful burning sensation in the chest under the sternum. Often called heartburn, this condition is clinically known as cardialgia or pyrosis and more commonly referred to as acid reflux. Pain is often accompanied by gas, gastric bloating, or a bitter taste in the mouth. While heartburn can be caused by too much fat in the diet, consuming spicy foods, obesity, or even pregnancy, it can also indicate the presence of an ulcer or a hiatal hernia, which is a condition that occurs when a superior portion of the stomach gets irritated or trapped at the esophageal opening in the diaphragm. Frequent bouts of esophageal irritation can lead to damage and structural changes in the esophagus, a condition known as gastroesophageal reflux disease, or GERD. When working with clients who have GERD, manual therapists may need to position them in a semi-reclined position since lying flat can exacerbate heartburn symptoms. While direct manual pressure over tender areas should be approached with caution, manual therapy techniques that help move the stomach away from the diaphragm, especially where the esophagus passes through it, can help alleviate pain, tension, and spasm. In our next pathology alert, we will consider peptic ulcers. Peptic ulcers are sores or lesions in the mucosa of the GI tract that do not heal, leading to long-term inflammation and tissue loss. Most commonly found in the lower esophagus, stomach, or duodenum, these lesions are most often due to the bacterial infection, specifically the bacterium Helicobacter pylori. Peptic ulcers can also be caused by long-term non-steroidal anti-inflammatory drugs, or NSAID, use. These factors damage the mucosal lining, making it unable to effectively protect the tract wall from the strong acid and pepsin produced by the stomach. Signs and symptoms of peptic ulcers include heartburn or gnawing abdominal pain, bloating, burping, nausea, or vomiting. If left untreated, ulcers can penetrate through the epithelial lining into the submucosa and begin to bleed. In their acute phase, ulcers are considered a local contraindication for any form of direct manual therapy, such as massage. Let's now consider irritable bowel syndrome in our pathology alert. Irritable bowel syndrome, or IBS, is a functional condition rather than a structural disorder of the colon. It is characterized by abdominal bloating, distension, and pain, as well as constipation or diarrhea. Its symptoms are often aggravated by stress and diet. Little is understood about IBS, and there is no definitive diagnostic test for the condition. While commonly diagnosed in adolescence or early adulthood, its symptoms can mimic those of parasitic infestation, celiac diseases, food allergies, or chronic GI tract infections, making diagnoses difficult. IBS affects more women than men, especially those who have experienced psychological trauma or abuse and is often associated with chronic fatigue or fibromyalgia. Because of its stress-reducing and relaxation benefits, manual therapy is generally indicated for people with IBS. However, because a client's IBS symptoms can vary widely from week to week, the specific techniques and body areas treated should be modified to match. Okay, so we have reached the end of today's lecture, and for assignment number 14, we're going to use the Thinking Beyond format to complete this assignment. Why might a client who feels chronically stressed and burdened have digestive challenges? What supportive measures might you offer within your scope of practice? How might understanding the detailed digestive process change the way you consume food? And visualize the structure of the GI tract. Where do you see a similar structural pattern in any other body system you've already learned about? Now, as always, if you have any difficulty with this assignment, which is due by 11:55 this coming Sunday, please send me a text message or an email. My office hours are always the same, from Thursdays from 4 to 6 p.m., sorry. From 4 to 6 p.m. And as always, I look forward to receiving your assignments, and I will see you in the next lecture.